Good afternoon to everybody east of Thunder Bay and good morning to the west. Welcome to the Canadian Patient Safety Institute's 6-part webinar series focused on knowledge translation and implementation science. My name is Christopher Thrall. I am the Communications Officer with CPSI and will be your MC for the webinar. I would like to welcome you on behalf of our web host, Tricia Swartz, CPSI Patient Safety Improvement Lead, and our technical host, CPSI Project Coordinator, Gina Peck. Our call today is the 5th in this informative 6-part series. In this discussion, we will focus on providing concrete approaches for identifying barriers and enablers and for emphasizing behavior change approaches. While this series is best enjoyed as a whole, you're always welcome to attend any one, several, or all 6 webinars in the series. If you miss a webinar and you want to catch up, please know that all are recorded and available on our website the week following their webcast date. It gives me and CPSI incredible pleasure to introduce our speakers for this webinar, Dr. Justin Prousseau and Dr. Andrea Patey. Dr. Prousseau has a PhD in psychology from the University of Aberdeen. He has been awarded Early Career Awards from the UK Society for Behavioural Medicine, the International Society of Behavioural Medicine, and the European Health Psychology Society. He's an associate editor for the journals Implementation Science and Applied Psychology, Health and Wellbeing. Dr. Prousseau is a scientist at the Ottawa Hospital Research Institute and an assistant professor in the School of Epidemiology and Public Health and the School of Psychology at the University of Ottawa. He is the scientific lead for knowledge translation at the Ottawa Methods Centre. Dr. Prousseau's research program operates at the intersection between health psychology and implementation science. He draws upon behavior change theories and methods to understand factors that promote and undermine behavior change in healthcare settings, and then designs and evaluates theory-based strategies for promoting healthcare professional behavior change to increase best practice and reduce non-evidence practice in healthcare. Dr. Andrea Patey holds a PhD in health psychology from City University of London and is a senior clinical research associate within the Centre for Implementation Research at the Ottawa Hospital Research Institute. Dr. Patey's interests in knowledge translation and implementation research include the application of psychological theory and methods to explain and change health professional behaviors across a range of clinical settings. Her interest in behavior change focuses specifically around whether implementation and de-implementation differ, and if interventions to target each should differ. The broad objectives of her research are to promote the delivery of evidence-based healthcare through the development and evaluation of complex behavior change interventions. Dr. Prousseau and Dr. Patey will talk for approximately 40 minutes, allowing us 15 minutes at the end for questions and conversation. Please write your questions and comments in the question and answer box or the chat box, and they will be compiled and provided to our speakers at the end of the call. If you run into IT difficulties, please connect with us in the chat or question and answer box, and we would be happy to assist. Without further ado, CPSI is delighted to welcome our speakers for today, Drs. Justin Prousseau and Andrea Patey.
Thanks so much for, as ever, the much too kind introduction, and thank you all on the webinar, on the call, for making the time in your day. For those of you who are joining us for the first time, welcome. But for those of you for whom this is the 5th time, thanks for staying along with us. So the topic of this week's or this webinar is building on the previous one, where we delved last time. For those of you who attended or who caught up on the slides, we delved into the sort of the nitty-gritty of the theoretical background to identify barriers and enablers. And in this case, in this webinar, we're hoping to provide you with some more concrete tools and suggestions for how you can operationalize some of those nitty-gritty suggestions that we talked about last time. So hope that sounds like a good way to spend your hour. But just to situate ourselves, as we always do, what I'll start with is walk us through where we are within the series. We'll do a very quick refresher about the framework that we covered in detail last week, just to remind ourselves the theoretical domains framework. But we're going to spend most of our time today introducing you to specific tools and practical approaches on how to especially use or assess barriers and enablers to implementation using this framework. And we'll cover some quantitative approaches and some qualitative approaches. But before we get into that, for those of you who are on the last webinar, there were at least one, possibly 2 people that asked a question at the end about whether there are any broad resources available, introductory resources covering knowledge translation and implementation science. And so we promised to dig those up for you. So these are probably three that we certainly recommend. All three of them are books. The first is by a group from the U.S. where they describe the field as disseminant implementation research. The second is a little bit older, but both Andrea and I sort of cut our teeth with this particular book, and I find it's just extremely helpful, the Grohl and colleagues book. And then finally, a more homegrown resource by Sharon, Jacqueline, and Ian Graham that get into the ins and outs of knowledge translation and healthcare from a Canadian perspective. And this is also, if you Google the latter, there are lots of resources on the CIHR website where some of this is hosted as well. So hopefully these are additional helpful resources for you if you wanted to get a broader overview of some other factors or concepts within knowledge translation and implementation science. Also, just as we do in all our webinars, just to flag that our perspective on knowledge translation and implementation science is distinctly a behavior change one, because we argue that successfully implementing any patient safety program really needs people to change what they do. The key actors, whether it's patients, health providers, managers, or policymakers, have to ultimately change their behaviors and their decisions in the complex healthcare environments in which they work. And so rather than reinventing the wheel rather than reinventing the wheel, we feel that it's important to draw on the substantial evidence base within the behavioral science that can help us to support the development of patient safety programs and hopefully increase the likelihood of success, given how much we already know about how people make decisions and change what they do. So in the webinar series, we're hoping to build some capacity in some of these basic principles and practice in KT and implementation science, and we've covered a number of topics already, and as I mentioned, we're delving into some practical examples in this webinar. We've used previously the knowledge to action framework to situate ourselves. So as you'll remember in the second webinar, Jeremy Grimshaw outlined the middle piece of the knowledge to action framework, which is all about the knowledge creation funnel, which ultimately leads to the development of some sort of knowledge product or tool or an evidence base to be implemented. And that's really just the start of the process rather than seeing this as an endpoint, because we know that merely disseminating a decision aid or a clinical practice guideline, for example, isn't necessarily going to guarantee that it will be implemented in practice. And so that's the purpose of this framework, is to outline the next steps, and really the purpose of this webinar is to walk us through approaches for doing that. So the third webinar, as you'll remember, for those of you who are on it, we talked through really pinning down where there are gaps between what the evidence suggests and what current performance looks like in practice. We highlighted the importance of really pinning down who needs to do what differently, and using a tool called the TACTA, or Target Action Context Time Actor, to really pin down the specific actor's behavior that we're focusing on. And then we're worried about this as an endpoint, again, because there's a temptation here to say, we know what the problem is, let's jump to a solution. And so we've actually taken the time to, the previous webinar and this webinar is really to drill down into, let's make sure we understand the problem in more detail, and drawing on theoretical frameworks so that we can build learning across settings and build a cumulative knowledge base rather than jumping straight to solutions. So we talked through that in detail, as you recall, in the last webinar from a theory perspective. And in this case, we wanted to introduce you to some of the tools that we use in the everyday practice and research within our settings for assessing barriers, and not just to assess barriers for the sake of it, but to the approaches we take are directly selected because they're helpful, at least from our perspective, to link directly into how do you select and tailor your subsequent implementation interventions. And that we'll cover in the final webinar with myself and Jeremy Grimshaw next in June. But for now, we're going to delve down into the more practical approaches to assessing barriers. As always, we're using hand hygiene as our sort of case study to highlight different concepts. So I won't belabor this one. We've covered this in each of the sessions. So basically, hand hygiene remains a problem and worthy of focus of attention to develop theory-based interventions to improve it. Last time we also talked about, if you recall, the TACTA tool for unpacking the who, the where, and the what, and the how in more detail. So in other words, if we apply hand hygiene to this particular tool, we're talking about the action being using alcohol-based hand gel, the actors being physicians, nurses, and residents, the target being potentially the patients receiving care, so it could be more specific if we wanted to, the context being in the patient rooms and the hallways, and the time being before and after touching a patient. Again, this is just to pin it down to exactly what barriers, what is the actor and the barriers that we're focusing on for our barriers assessment. And just to refresh your memory also where we're at with this other model, so we covered step one, who needs to do what differently, and we're again drilling down into the factors that determine why they don't. In other words, the barriers and enablers. Okay, so that's a very quick whistle-stop refresher. Hopefully for those of you who were on the last call, that was helpful, and those of you who are new, hopefully brings you up to speed. So let's dive into this more practical aspects in a bit more detail. So if we use the theoretical domains framework as a basis for informing an assessment of barriers and enablers to implementation, there are a range of different approaches that we can take to effectively assess those barriers. So we can speak to people, so we can conduct interviews one-on-one, or we can bring people together and conduct focus groups. And that predominantly is the way that this particular framework has been used in the literature, though not the only way, and predominantly with healthcare professionals, but not necessarily, can also be with patients and other people within the organization. But there's also questionnaire-based approaches or surveys to descriptively understand how larger groups of people respond to these to barriers as assessed by the TDF. You can also observe and watch people engage in hand hygiene behavior and using the hand gel. That requires a bit more inference, but particularly for aspects of resources and environmental and social impacts, can be useful to do observations. And then finally, you can also draw on what others have done and in a sense, re-engineer existing interventions to understand what factors or what barriers they were targeting rather than, or in addition to conducting these other primary data collection sources. But regardless, we feel that drawing on a theory, and in particular the theoretical domains framework, the TDF in this case, has a number of advantages because it's applicable across a range of targets, action, context, times, and actors. It covers a wide breadth of factors that we know are linked with what people do and how people change their behaviors. And from my perspective, what I find most helpful of using this particular framework as opposed to some of the others is that it most helps, compared to some of the others, it helps you to more directly link specific strategies and techniques that are best suited or fit for purpose for addressing some of these barriers and enablers, which we'll cover in the next webinar. So this is the theoretical domains framework, as you'll recall. We can split this, as you also remember, into three broader categories. So in the green, these are all factors linked to whether people have the capability of engaging in the behavior, so the knowledge, the skills, whether they feel they can do it, whether they remember, whether they can continue doing it by regulating their behavior. The blue factors are opportunity factors, so whether the social environmental setting supports them or not in doing it. Whereas the yellow are focused on more motivational aspects. Do they want to do it? Is it a priority for them and the organization? Do they see it as part of their role? What do they think will happen to themselves and the patients if they do it? Are there rewards or punishments in place that might help or prevent them from doing it? How do they feel about it, and how optimistic are they about it? So in a nutshell, those are the key factors. So the first tool, a published tool that we wanted to flag to you, is published last year in Implementation Science with Dr. Pady as a co-author, which I find just a really helpful step-by-step process of how to actually conduct a TDF-based assessment of barriers and enablers. So it really walks you through from the starting point of selecting and specifying your target behaviors, using the TACTA, for example, helping you to select what is the best design for assessing the barriers, what to consider when developing materials, what factors to think about when sampling, so how do you decide who you're going to speak with or send surveys to or observe, through to collecting, analyzing, and reporting the findings. we'll talk through some of these steps, both from a quantitative approach and from a qualitative approach. So just going back for a second, the first point or the first step within that guide is really to select and specify the target behavior, which we've done, talked through with our TACTA principle, building this up. The next step is selecting the design. How will you actually collect your data? So we talked about that a little bit already. You can do interviews, focus groups, observations, or questionnaires and surveys. So we wanted to drill down into each of those in turn. So I'm going to spend a bit of time highlighting some existing published validated questionnaires that you can use in your own settings as a basis if you wanted to go down the more quantitative route. And then Andrew is going to walk you through how you might go about developing topic guides to actually conduct semi-structured interviews to identify barriers using the theoretical domains framework. But again, recognizing that the predominant method of collecting data using this particular framework and many others, to be honest, tends to be a more qualitative approach. So what I'm going to talk about here on the questionnaire side is not done as often, but it has its advantages that we wanted to flag to you. So assuming you might be interested in assessing barriers and enablers using a questionnaire, really the aim of that approach would be to more descriptively quantify people's views on each of the TDF theoretical domains framework domains, which would help you, first of all, either identify which of the domains from the 14 available have high versus low mean scores, so it's a bit more quantitative in that respect, but it might help you to get a sense of, is there room for improvement in knowledge, or is everyone scoring very high on the knowledge versus motivation versus role? So it can help you gear your assessment quantitatively using the mean scores. And it also helps you to get a sense of how people quantitatively vary. So is everybody saying that they have the background skills for washing or for using the hand gel, or is it relatively variable? And so that quantification of these factors can be helpful in making a decision about what to focus on in developing an implementation or a KT intervention. From my perspective, that's probably the best use of a questionnaire-based approach with the TDF at the moment. But given that you are effectively collecting data, quantifying factors on these domains, what you can do is actually run more sophisticated analysis if you're so inclined, starting with, for example, assessing what is the relationship or the correlation between answers to skills versus knowledge versus, all the TDF domains, and hand washing, for example, if you have access to that measure of hand washing itself. So would allow you that additional layer of quantification of the relationship. That tends not to be done currently in the literature as much, but it's certainly an option that you can use given that you've collected the data. So this may be somewhat obvious if you've done lots of questionnaire work yourself or participate in it, but we felt it might be worth just highlighting some of the practicalities, and this is in particular to juxtapose against the qualitative practicalities that we'll talk about in a bit. So the first major consideration is, at least from our perspective and our experience, most of the time commitment when you're planning a barriers assessment study from a questionnaire side is before you collect the data. So getting the questions right, pilot testing it to make sure you're very comfortable with how the questions are asked and your respondents interpreted. That most of the time commitment is before you collect the data, because once the survey's out, there's no room for changing it, obviously. And once you collect the data, relatively speaking, the analysis side is more straightforward, as opposed to the qualitative side. It's the reverse. Most of the time is in the qualitative analysis after you've collected the data. Practically speaking, it's important as much as possible to select previously used or even validated scales where they're available, rather than developing new scales. Obviously, if there isn't a scale available measuring what you want, that justifies developing your own, but as you'll see, there are a few existing scales that you might want to draw from, and by using them, it just allows for comparability across different barriers assessments. Cost tends to go down now that we tend to use online data collection, but there is some evidence in the literature looking at ways of collecting questionnaire data that might suggest that you might want to consider postal surveys as a novel way of collecting data, and obviously there's a cost to that. Recruitment, as always, can be challenging. When we're talking about quantifying and using questionnaire-based studies, we're usually thinking about larger samples, which usually means trying broader recruitment strategies. But it's worth being mindful that, and I'm sure you're all inundated with questionnaires in your inboxes as well. And so we just need to be mindful that recruitment is an issue, and retention is an even greater challenge if you want to ask people these questions more than once. Data entry, obviously time-consuming unless you're doing it online. Missing data, so we often don't think about this until we actually receive all our data and realize that some people either systematically omitted whole sections, or they may have missed certain aspects in it. So it's worth thinking about that from the start. How are you going to deal with this? And depending on the level of your analysis, you may need larger number of respondents. So if you go down the more inferential stats route, like the correlations or even regression route, I strongly urge conducting formal sample size calculations before you start to collect your data. But if you're talking about more descriptive, looking at means, averages on the scales, that may not be as important. But certainly, if you're wanting to look at what is the correlation between motivation scores and hand washing, for example, take the time to run a formal sample size calculation, or involve a statistician that can help you to do that. So assuming that you might go down the route of designing a questionnaire or wanting to use a questionnaire to assess barriers and enablers, so we've covered defining your TACTA, use an existing scale where possible, decide on your sample, how you will sample, how you decide which actors, which people you will sample from. And the fourth point I just wanted to flag is we often think that this might be quality improvement type research in some cases, but I find it helpful to actually publish some of these barriers assessments where possible. And if that's something that speaks to you as well, it's worth taking the time, if possible, to get ethics approval, even to do barriers assessment, because the advantage there is if you do want to publish it or partner with someone who can publish with you, then we can learn from your experience in assessing the barriers, especially if you're drawing on a framework like the TDF. Then even if someone else somewhere else in Canada or around the world might be engaging or developing a patient safety initiative, if they can see the barriers that have come up in your setting using this more generalizable framework, that prevents them from either repeating if they don't need to, or at least learning from your experience. And depending on the journal that you send it to, they often require ethics approval, even if your participants in this case are healthcare providers. So just be mindful of that, and if you do want to go down that road, build in the sufficient time for getting the approvals, which can usually take weeks, sometimes months, depending on the board that you send it to. So just more of an aside, but something to think about. So let's take our TACTA, physicians and nurses using alcohol-based gel in the hallway before and after entering a patient's room over the next month as an exemplar. So two specific existing validated TDF questionnaires that we wanted to flag to you are one published by a team in the UK, led by Natalie Taylor, 2013, which is specifically developed with patient safety related implementation behaviors in mind, so especially I think relevant for those of you on this webinar. So we'll drill down into that one in particular. The second one that we'll flag and not drill into too much detail is led by myself and a group in the Netherlands that was designed to be a bit more generic and applicable across a range of different settings, including patient safety settings, but not necessarily only those. But we wanted to flag both of these as examples of effectively ready-to-go questionnaires that have been well tested and validated, that you can use as a basis for thinking about conducting questionnaire-based barriers assessment in your setting. So drilling down into the first tool, the Taylor and colleagues measure, this involves 23 different questions or items that were developed and validated to assess responses to questions on the TDF, covering 2 items per domain. I think one domain might have 3. And they explicitly designed this with stakeholders to make sure that it can be completed very quickly, so within 5 minutes, which is clearly very attractive when you're trying to get responses from busy professionals. So it's something to think about as when you're thinking about weighing questionnaire approaches versus interview approaches. Just that the time commitment required is also something to factor in. It takes a lot less time to fill out a questionnaire than it does to conduct an interview. So we put in a link here, which you may or may not be able to click, but certainly if you Google the name of the authors and the title of the paper, in their additional file too, they have effectively the Word document of their survey that you can use in your setting to adapt it to your setting. So the ratings, the way that this questionnaire is set up is that respondents are asked to rate each item on a Likert scale, and the analysis was really just getting a mean or an average and a standard deviation or the variability for each of the different domains. So in the interest of time, I'm obviously not going to read through all of these in detail, but just to flag that these are the questions within the survey. So for example, I know what the guidelines say about the need to ... and then you would fill in your target action context time after each question so that you get a sense of how this particular measure relates to the behavior of interest that you're trying to get a barriers assessment on. So there are two items for every domain, and can be completed relatively quickly on a Likert scale. So same thing for the opportunity questions for environmental context and resources. This is the one I think that has 3. And so it's covering things like there's not a good enough system in place to do this, verbal written communication between staff is clear, have the necessary resources, and then the social influence, other staff don't do it, and versus whether your supervisors or superiors would like me to do it. As I say, this has been developed with stakeholders in a patient safety setting. And if you read the paper, you'll see that in detail. And they've actually then went on to test and validate the tool itself in quite a lot of detail. So the items are there so you can use and adapt in the sense of adding your own ... tacta behavior to the setting itself. And if you download the Word document of the survey, you'll see it's really straightforward to adapt to your setting. From an analysis perspective, effectively what you would end up doing, or what you would end up having, is responses like those in the figure here. So people would circle, for motivation and goals, emergencies and other priorities get in the way of me being able to use alcohol-based gel in the hallway before I see each patient. They might agree to that one. The second one, other guidelines conflict with trying to use alcohol-based gel in the hallway before I see patients. They might disagree. So for every person, for every domain, you'll get a mean score between, and you can then get an average or mean across people, and that starts to give you the ability to assess where your overall sample lies in terms of do the barriers seem to be all around motivation and goals, or are there other domains that are worth focusing on? And it gives you a quick snapshot of being able to do that. It doesn't give you the depth in any way. It doesn't tell you specifically what the detailed barriers might be, although you get some of that in the items themselves. That's where the qualitative piece might come in. But as a method for quickly scanning where do the issues seem to be from a barriers perspective in the TDF, this more descriptive, summative approach can be helpful. The second that I wanted to flag, as I mentioned, was another tool that I was involved in developing. The main distinction between this one, as I say, is it's generic. The other main difference is, whereas the previous tool, the items that were developed by the team themselves and then validated, what we did in this for this development was we actually went back to literature to identify existing validated scales for each of the constructs or each of the domains as much as we could, and then identified how we could build in the tacta within each of the questions. And so they both serve a similar purpose, but probably if we had to give advice, I would say start with the tool developed by the team in the UK, especially for a patient safety initiative, and then you might want to consider whether this second tool might be of any value. So that's the questionnaire side of things, or the more quantitative way of quickly getting a sense of where the barriers might or enablers might be located specifically within the TDF on the quantitative side of things, but I'll hand it over to Andrea, who is going to walk you through the interview approach to doing this.
Thank you, Justin. So just to recap, Justin has gone through the questionnaire side of using the TDF, and I'm going to run through the process of developing your study materials, collecting your data, analyzing the data, and reporting of your findings if you choose to do interviews, whether they be semi-structured or focus group interviews. That's what I just said, so I'm going to skip this slide. So in the development of your study material, the first thing you want to do is develop an interview guide. So what are the questions that you're going to be asking the people? Initially, you're probably going to start with a literature review around what the topic, the TACTA that you've discussed. You may have done that already. So in the instance of hand hygiene, I just took some pretty general information here that it's a leading measure to reduce healthcare-associated infection. The compliance is really low, and apparently physicians in particular are repeatedly observed as being poor compliers. So within your institution, you may want to talk to some people who are directly responsible for, in this example, hand hygiene, to identify some of the core issues in the behavior that you're interested in, which can then help inform the questions that you include for your investigation. And you may go through a number of drafts of those questions. We do have suggestions around not necessarily starting with a blank page. So within the journal Implementation Science, there was the TDF series that was published in 2012. There's probably a dozen or 15 papers in there right now. And within each of those publications in supplemental material, pretty much every author has provided their interview guide. So we suggest that you don't necessarily start from scratch and probably take a couple of guides and see if any of the questions seem relevant or important to your area of interest. Once you get your interview guide designed, you're probably going to want to pilot test the interview guide. And this is to make sure that there is validation of the guide from a theoretical perspective and from a clinical perspective. So do the questions target the domains that you want to investigate, and do the questions make sense from a clinical perspective? You will find that sometimes when psychologists word questions, clinicians have no idea what they're talking about. So it's important that you get that feedback from clinicians as well as the psychology or behavioral perspective so that you match both the theoretical importance and the clinical importance. And you will then, because it's a slightly iterative approach, you may want to make some changes based on those pilot interviews. So the next step is about developing your sampling strategy. And one of the big questions or things you may want to consider is you want to maximize the variation in this type of exploratory study. So you would hope that you wouldn't get everybody who is a complier to the behavior, because that doesn't necessarily give you any information around what are the challenges for those who are non-compliant. So you want to identify key participants who will or should perform the behavior, but it can also include other stakeholders. From my own experience, I was involved in a study looking at preoperative testing for anesthesiologists, and I quickly discovered that anesthesiologists are not the only individuals involved in making decisions around what tests are ordered for acute or ambulatory surgeries, and I found out in smaller hospitals that sometimes surgeons are involved. So initially I thought I would only be talking to anesthesiologists, and I quickly found out that I needed to talk to surgeons. So I then added them as a group in the interviews so that I could get their perspective about how they are involved in the behavior that I was investigating.
One thing I wanted to mention there, as Andrea was saying, that is another major advantage of the qualitative approach is that it has this built-in flexibility that isn't as straightforward in a questionnaire-based approach, and so you can iterate and even add additional groups of participants as your findings sort of emerge from ongoing analysis within the qualitative.
Yeah, there's a level, definitely a level of flexibility within the qualitative approach that's not necessarily there in the questionnaire or the quantitative approach. So you conduct your interviews, and then there's the question of, well, how do I know when I've done enough interviews? Do I need to interview everybody in my department? Do I need to go outside of that department and into the hospital? We have a suggestion around how many people you should interview, and that tool was published in the journal Psychology and Health, which gives you 3 strategies for operationalizing your data saturation for your interview study. One of the other things that should be noted is that when Justin was describing the quantitative component of, or the quantitative approach to using the TDF, you are likely going to be going to a larger population of 60 to hundreds to thousands of people, depending on the scale of your investigation and your sample size calculations. Within an interview study, your sample sizes are considerably smaller. You may be interviewing 10 to 15 people, depending on the complexity of the behavior. So when Justin talked about the volume of work around about conducting these types of studies, when you do quantitative studies, their work is front-end loaded, and when you do the qualitative, more interview studies, the work is back-end loaded. So collecting the data is pretty easy because you only need to talk to 10 to 15 people or so, but the analysis is the part that becomes a bit more complicated. So just to give you some quick tips on conducting an interview, with respect to the theoretical domains framework, it is a semi-structured interview. So while it's important to stick to the framing of the questions in the guide, there's also an opportunity to prompt. So when you ask your questions, it may seem like from a behavioral psychology perspective, you have to frame it in a certain way. But oftentimes we use prompts because a lot of people don't talk around theoretical domains. And you want to be able to get as much information and the richness of their answers while sticking to the original question. The prompting allows you to explore any sort of novel or unclear ideas that may come from the interview itself. As with all qualitative interviewing strategies, effective interviewing always requires a standard interviewing competencies, and it's also helpful for when using the TDF that you have some understanding of the theoretical content within each domain. So as I mentioned before, the analysis component using qualitative approach is a bit more heavy than the quantitative approach. There's usually 3 stages. So you would have your transcripts, your interviews transcribed, and then you would code text from those interviews into each of the 14 domains. As I mentioned before, just to give you some ideas around the practicalities of using the TDF and doing any type of qualitative studies, it's important that people recognize that interviewing is a skill that requires practice. So when we pilot test the interviews, you're also practicing your interviewing skills. You want to avoid leading people, and you also want to avoid closed-end questions that generate yes or no answers. Sometimes you have to ask those questions when you're asking somebody about their intention to do something or their goals or priorities, but you always want to follow that up with a why or a how question so that you get that extra bit of content or extra quality within their question. It's always important to keep people on track. Sometimes questions or interviews can go completely off the rails, especially when you're talking to someone who's just coming off a 12-hour shift. And as I mentioned before, it's really important to pilot and practice your interviews because the more you practice, the more comfortable you become with the questions that you're asking. as I said before, the majority of time commitment for qualitative research is in the analysis, so after the data has been collected. We audio record our interviews, but you may want to digital video record them because sometimes you can get nonverbal cues in those interviews that may help inform your barriers and enablers assessment. Transcription is time-consuming. If you're doing something nationally, you will also have French language components, so you may also have to do translation as well as transcription. So that, again, is another component involved in the qualitative studies. We have often used double coding. That improves the robustness of your analysis. I'm a firm believer in coding all interviews double-coded. There are others who will do a percentage of the interviews double-coded and then kind of do a check of the theme generation, and I'll get to that later. And then the software that we find very helpful is an in vivo software. It's not necessarily the cheapest software out there, but it does do a very good job of collecting the information that you need from the interview transcripts. Excuse me. So when coding into domains, that language may sound like, what the heck does that mean? But basically, you have two researchers who will read the transcripts, and you will take components of the text within those transcripts and basically identify that as belonging into one of the domains. So it might be about social influences. Initially, when you do this, if you're new to the TDF and using it, the two researchers that are coding, or the two people that are coding, may want to do a couple of interviews together so that they both have an understanding of what the domains mean and what sort of information should go into those domains. One way of checking this, sorry, before I go to that, basically, as I said, it's about those two individuals having an agreement between them as to what will go into each of the domains, and then what you do is you create a guide around these agreements that you've had, and you may want to use guides that have been established by other people. If you, again, go on to that series from the Implementation Science Review, you can probably contact any of the authors who would be willing to share with you their strategies for coding into the domains and provide you with their coding guides. It took us, when we first started doing this, 4 interviews to set the guide. The more you become familiar with using the TDF to code for your interviews, the easier it will get to setting up those guides. We have calculated kappa as a way of reporting our agreement within our domains. You don't necessarily have to calculate kappa, because what you do is at the end of this stage, if there are any disagreements around somebody coding it in one domain and another person coding the text in another domain, you would sit and discuss it. So you always come to a consensus once you've gotten to the point where you're discussing either the disagreements or agreements. So I'm cognizant of time. I'm just going to give you an example. So we asked a question around hand hygiene about not practicing. So are you ever worried or concerned about not practicing hand hygiene? And the individual said, no, it wouldn't code and it wouldn't create any concern. So when you see that text, you would identify that as part of the emotion domain, because they're not concerned about not doing hand hygiene. So another example is an individual said, I think that patients and families have reason to expect hand hygiene from us, like I don't do it to satisfy them or their wishes. And so this would come into the social influence domain, because it's about the patients and families' influence on whether or not they perform hand hygiene. So the second component is generating specific themes. So it's about taking those coded statements and identifying similar similar components, that general ideas that come across everybody's comments. So they're basically statements that are made from different participants, and what you're doing is trying to capture the core thought across everybody's statement. If a statement is made by different participants, you code both of those instances in the same theme. And then what you would end up doing is taking the themes, and if they're the same theme or polar opposite themes, they're grouped together. That may seem a little bit complicated, so I have an example to go through. And so one of the two people who were involved in the coding would do this, and then the second person involved in the coding would then review this strategy to make sure that nothing was missed or changes weren't made. So, for example, one person in the hand hygiene, under social professional role and identity, you coded these two statements into this domain, and basically it's one person has said, I like to make hand hygiene a very visible part of my patient consultation. I make sure that I'm actually still in the process of putting on the alcohol-based hand rub, so that the patients know I'm performing hand hygiene. And then a medical resident had said, I think every healthcare professional has to use hand hygiene. So the general theme around those two statements is that hand hygiene is a standard part of my patient consultation. And to provide an example for barriers, individuals may say things around, I don't think I was ever trained around hand hygiene, and so any idea around their training or not being trained would be themed into not having any training in hand hygiene practice. And in the belief about capabilities domain, any confidence around or lack of confidence around hand hygiene or following hand hygiene guidelines would be collapsed into one theme. So what you end up having is in the next phase is identifying which domains you may want to develop your intervention around. And one of the ways that you may want to identify those domains is through a consensus process of your team within your institution, which may include people who know the clinical behavior very well and those who are comfortable in using understanding the domains themselves. One of the things you may want to consider, or when you consider identifying what are relevant domains, there are three factors that we often use to identify the relevance, and they are frequency of beliefs or themes across the interviews. So if an issue has come up, if there's a lot of different issues that have come up within a domain, you would identify that as relevant. Whether individuals have conflicting themes around confidence or around the behavior itself, or this is more of the clinical component, so it's the perceived strength of the belief impacting the behavior. So if somebody doesn't say it a lot, but it seems like it's a big issue or a big barrier, then it may be something that you want to include or you want to identify as a major component of the domain. It's important to recognize that all of these factors should be considered concurrently, so you shouldn't necessarily focus only on the frequency of behavior. You shouldn't focus only on the presence of conflicting beliefs. You should take all three of these components together. So if we're looking at identifying a relevant domain, we have the items in red are the quotes from the interviews. And what we have here right now is a theme around hand hygiene being easy to practice, a theme around hand hygiene being difficult to practice, and a context-specific barrier to performing appropriate hand hygiene. So it's an indication that there's variability in people's belief in their capabilities to perform hand hygiene, and there may be something that's context-specific that we may be able to target in an intervention. So this is an indication to us that belief about capabilities is a domain that may be relevant to designing the intervention. At the end of it all, hopefully, you'll have a list of relevant theoretical domains that have identified barriers and enablers to the behavior change or the behavior that you want to develop an intervention around. And just as a resource for you, all of our examples have been taken from a study conducted by Janet Squires here at the Ottawa Hospital Research Institute around factors that are influencing hand hygiene compliance within the Ottawa Hospital. So just to summarize, and hopefully we've been able to give you some take-home messages around the TDF, both from a quantitative perspective and a qualitative perspective. The TDF can help structure how you identify the barriers and enablers that may influence the implementation of your initiative in your setting. You can either use a quantitative, i.e. the questionnaires, and or a qualitative approach, or you can use a combination of both. We hope that we provide you with some tools that you can use and quickly adapt. You don't necessarily need to reinvent the wheel. Questionnaires and interview guides are out there that you can then adapt to your setting. And I think, I mean, we've probably talked about the TACTA ad nauseum, but I think it's important, I can't stress how important it is that if you can identify your behavior clearly as a TACTA, it makes the analysis in your qualitative interviews infinitely easier because you are always asking yourself, what is the behavior under investigation and how is what they're telling me going to influence that behavior? So it's really important that you develop that TACTA. So if we look at it from a comprehensive and structured approach, if we know that, trying to understand this last sentence, I think this, oh, right, I got it now, sorry. If we take this comprehensive and structured approach, what you will have is at the end a list of barriers and facilitators that you know influence behavior and then can help behavior change, which then will help you start selecting strategies that are fit for purpose in your clinical context with your group of individuals that you can then try to practice, you can then try to change the behavior in your environment. And that is the next webinar with Justin and Jeremy. Oops. So we went over, apologies.
No worries at all, Andrea. Thank you so much. And Justin, terrific presentation as always. Thank you both so much for your time on this. I just want to mention that this webinar series is available on our website, and Tricia did send out the link in the chat box. Episode 4 will be up by the end of this week, and this recording will be up within the next 2 weeks easily. So I did actually get some comments and questions from the attendees. The first comment of which I just wanted to thank Marilyn for, because she thanks you for, you, Justin and Andrea, for the primer on creating questionnaires. The information was exactly what she was looking for. In her experience, questionnaires are often created with enthusiasm and good intentions, but difficult to obtain meaningful data afterwards. That actually ties us to our first question really well. Justin, you noticed in the practicalities to be mindful of slide and some challenges to be aware of when using the TACTA and TDF resources. Have you ever used those frameworks and come out with the wrong conclusions, so leading you to the wrong barriers and the wrong enablers? Is this a potential risk when you're using these tools?
That's a good question. I can't think of an example of wrong. I think I see this as at least giving us a better chance of a better bet on what to focus on than we might otherwise do in another way. But I can't think of a situation where I could say it was the wrong, because we
you would have fixed it.
Yeah, hopefully, yeah. But I think, if anything, the utility of at least rooting it to a framework is that if you, for example, identify barriers, go on to select a strategy or strategies to address those barriers, and you find that, and you test your intervention and it doesn't work, it at least gives you something to build on and learn from, rather than saying, right, that didn't work, let's try something completely new. At least drawing on the barriers that you did address, you can either select other barriers, and we'll get to that in the next webinar, that there are sometimes decisions to be made from a practical perspective that which barriers you can actually, or how many barriers you can actually target in a given intervention may be dictated by practical reasons. But yeah, I'm not sure that fully answers the question, but yeah, maybe ask me in 10 years and I'll probably have a
Perfect. Just make sure everybody writes down the email address that you see on the screen right now and follow up with him. Second question, do you have any suggestions on how to choose between a questionnaire and an interview? If you've chosen a questionnaire and it doesn't quite give you what you want, would you then conduct an interview?
Yeah, it's such a good question. So, most of these studies tend to be interview-based, probably for two reasons. One, practical, in that you don't have to recruit as many people as you might need to from a questionnaire side. And the other, actually from a intervention design perspective, is that the questionnaires give you hints, but they don't give you anywhere near as much depth about what are the actual barriers as the qualitative might do. And so I think particularly if you're new to a setting or new to a particular behavior that you're trying to change or something to implement, the qualitative is often a better starting point, I would say, than the quant. Because you'll undoubtedly, and this happens every time we've done this, and we've done this, yeah, a few dozen times now, TDS studies, that things come up in the qual that that are surprising, and if you use the questionnaire approach, you would have missed because of its structured approach. And so, my first advice is consider qual before quant if you have to make the decision. If you can do both, you can also do them concurrently. So.
Yeah.
You can also use the qual to inform the quant. So there are some suggestions that to keep the surveys even shorter, you might use the results from the qual to pin down specific domains to assess quantitatively. So that's another approach. There isn't a one-size-fits-all suggestion. I think it tends to be what's practical within your setting.
And they each give you different outcomes, so it really depends on the outcomes you're looking for. So yeah, that makes perfect sense. I did have a request from the floor to actually please provide the link to the Patient Safety Behaviors Questionnaire. We can find the article, but not the full questionnaire template. If you can provide that for us, we'd love to put it up on the CPSI website.
Right, so it should be on slide 24. I don't know if I still have access to that. This, so it's sort of a mouthful in terms of the...
Perfect, yeah, no, I don't want to read it out loud either, but...
that hopefully works. If not, I can certainly send through the link, and that might facilitate things.
Beautiful, and we'll post it up on the website and supply it by email to anybody who asks. So,
great.
Perfect. And I just wanted to say thank you very much. I wanted to list the email addresses for further questions, just in case we didn't get to the question that you had in mind for Justin, Andrea, or CPSI. You can reach Justin Presseau at jpresseau, J-P-R-E-S-S-E-A-U at ohri.ca. You can reach Gina Peck at gpeck@cpsi-icsp.ca, or our general info line at info@cpsi-icsp.ca. So I do see that we're at time. I wanted to thank very, very much Drs. Presseau and Patey for sharing your time and expertise with us. Thanks, of course, to all of you for taking the time to attend. We know how busy your day is, and we appreciate you choosing to spend time with the Canadian Patient Safety Institute. Please visit our website for a taped version of the presentation today and to sign up for our final Knowledge Translation and Implementation Science webinar. On June 19th, we will welcome back Dr. Presseau and Dr. Jeremy Grimshaw to emphasize the importance of understanding the problem before brainstorming solutions to better ensure a match between barriers and the solutions. If you wish to sign up for this upcoming webinar, or if you want to continue this conversation started in the discussion, please feel free to send us an email. We will forward your comments and any questions you may have that were unaddressed on to Drs. Presseau and Patey. You should all receive Gina Peck's follow-up thank you email in your inbox shortly, and you can respond to that. Thank you again, Justin, Andrea, and thank you all for joining us, and have a wonderful day.
Thanks so much.
Thank you.
You bet.